Hi everyone, thanks for listening to my presentations. Today I'll be talking about a medication called calcitonin. Calcitonin, though is supposed to be a hormone, then I'm talking about the sciences, backing the hormone, but I'll limit myself to the use of calcitonin as a type of medication. Please sit back and let's go. Calcitonin could be called Fortico, that is a type of trade name, or Macacin, that is a form of spray or injection, or Casima, that is a form of tablet or injection, depending on your jurisdiction. Calcitonin is an antidote, and that's why I'm making this presentation. Okay, it's an antidote in the face of hypercalcemia. If you have been watching all my presentations in recent weeks or months, I've been working on renal system, the kidney stones, and very soon I'll be talking about hypercalcemia, and that's why I've brought in our good friend calcitonin at this time. So calcitonin is an antidote in the face of hypercalcemia. It is also a hormone. It's a 32 amino acid and a peptide. It is produced by parafollicular cells of the thyroid gland. It works purposely to oppose the activities of parathyroid hormone. And to those who are students of physiology, you agree with me that parathyroid hormone will lead to hypercalcemia. So, as parathyroid hormone has the power to shoot the calcium into the circulatory system, somebody called calcitonin has the power to bring it down. Reduction of blood calcium is the main effect of this hormone. The mechanism of action already should be clear from what I've said in the last 2 minutes. It inhibits the activities of osteoclasts, thereby preventing more calcium in the blood. Not limited to that, it can also decrease the resorption of calcium in the kidneys, preventing more calcium in the circulatory system. So two ways. The medication called calcitonin could appear in the form of injection, and sometimes you have 200 international units per ml. Could be in the form of nasal spray, could be Fortico or Miacalcin spray, or use it intramuscularly if you are given more than 2 ml. But you could use it subcutaneously, particularly if you want to give it to a patient who self-administer it. The nasal spray could be used, but you use one nostril a day and you alternate by using the other nostril the following day. When do we need it? We need it in the face of hypercalcemia, in Paget's disease, osteoporosis, osteogenesis imperfecta, and secondaries to burns, and of course, hyperparathyroidism. Someone may ask me, why do we need calcitonin in the face of osteoporosis? Don't worry, I'll get to that in a bit. In hypercalcemia, you can give it intramuscularly or subcutaneously using 4 units per kilogram every 12 hours. You have to review the clinical features after 48 hours. If you are not winning, then double the dose, which means increase to 8 international units per kilogram every 12 hours. You review again after 48 hours. If you are not winning, then you can increase to still the same unit, but more frequently. So you increase to 8 international units per kilogram every 6 hours instead of 12 hours you've used before. Then we have to check the calcium level and prepare your mind, prepare the nurses for hypocalcemia. If hypocalcemia ensues, what are we going to do? Okay, in the phase of hypocalcemia, you have to increase the calcium in the diet, or you administer vitamin D, or you administer supplemental calcium. Yes, somebody will ask me, oh, doc, you're talking about calcitonin and osteoporosis. Okay, here's the answer. Calcitonin is not routinely used in osteoporosis. Take that. It is used only when other medications have failed or they can't be used. In other words, when you can't use your alendronate and the rest, then you look for the services of calcitonin. Why do we still need calcitonin in the face of osteoporosis? Remember, calcitonin works by two mechanisms, right? It promotes osteoblasts. It inhibits osteoclast, right? Then more calcium is kept in the bones. That is how we use it in osteoporosis. But remember I said, it is not routinely used here. So you can use 100 international units per day, and you give that IM or subcutaneously. You may choose the intranasal passage using up to 200 international units per spray in one nostril each day. So don't make that mistake. One nostril, 200 international units today. If you want to use another dosage of 200 international units tomorrow, you use the other nostril that you will not use today. In Paget disease, you can give 50 units subcutaneously, and you use that alternate days, or 100 units subcutaneously once daily. In pediatric osteogenesis imperfecta, particularly in kids greater than 6 months old, you can use 2 units per kilogram per dose, and you can administer that 3 times per week, either subcutaneously or intramuscularly. What are the adverse reactions? Yes, we need to study this together. When you use the nasal route, you may be faced with rhinitis or epistaxis. Cardiovascular system may experience flushing, and there may be erythematous rash, nausea, abdominal pain, infection, myalgia, bronchospasm, and abnormal lacrimation. Still on adverse reactions, you may be faced with alopecia, anaphylactic shock. That is why you have to give the first dose with extra caution and get all your gadgets ready for resuscitation. Anorexia, diaphoresis, hypertension, hypocalcemia. Of course, that's what we expect, right? Polyuria, pruritus, tachycardia. Contraindications. Remember, I've just mentioned anaphylactic shock as a possible side effect or drug reaction. Hypersensitivity to calcitonin is possible, or hypersensitivity to salmon or any other component. Then you don't use it if that is the case. If there's hypersensitivity to calcitonin, don't use it. Zincalide. Zincalide is meant for the diagnosis of gallbladder and pancreatic dysfunction. You don't use calcitonin while trying to use Zincalide, please. Warnings. I don't like giving warning, but to save the lives of the human beings, we have to adhere to certain rigid rules. Hypersensitivity with possibility of anaphylactic shock and bronchospasm should be at the back of our mind while administering this medication. So that is a strong one. And we should be warned that our patients could be faced with tetany. Tetany is secondary to hypocalcemia. Therefore, we might get ourselves ready with vitamin D or supplemental calcium. Of course, the value of the calcium will guide against or for the use of vitamin D or supplemental calcium. There is a possibility of cancer formation with calcitonin usage over a long period of time. And remember, urinary sediments with coarse granular cast that will be containing renal tubular epithelial cells are possible with time. Drug interactions. Well, the details of drug-drug interactions could be obtained by you interacting with the pharmacist under the jurisdiction where you are practicing. But for the purpose of this short presentation, I will limit it to only 2 medications. When you are using calcitonin and zoledronic acid at the same time, you are bound to be faced with profound hypocalcemia. And if this is a patient that is having mood disorder and is being placed on lithium, then you are going to face decreased serum concentration of lithium. Monitoring. You have to monitor serial bone marrow density at the beginning of the usage of calcitonin and every 1 to 3 years. And of course, you have to monitor the serum calcium level periodically. Alkaline phosphatase is necessary to be assayed if you are dealing with Paget disease. And you need to know the serum level of vitamin D. You have to monitor for the pain in the affected individual on this medication. And get your gadget, check the nasal cavity place, because I've mentioned earlier that you could be faced with epistaxis and even rhinitis. Of course, you need to do your urinalysis periodically and look for sediments to give you a clue that might be dealing with stones here. And with that, I've come to the end of this short presentation as per calcitonin. Remember to share and continue to watch my presentations. You are free to leave comments or questions. I appreciate it.